All right, welcome back. We're on chapter 17, communication and documentation. All right, topics in this chapter are going to be communication systems and radio communication, the verbal report, interpersonal communication, pre-hospital care report, and special documentation issues. In this first section, we're going to talk about communication systems and radio communication. All right, so next is communication system. So there's a number of components to any radio or communication system. So we'll start with the base station. So the base station is set up with two-way radios that are at a fixed site, such as a hospital, your fire station, your ambulance garage, or even the dispatch centers. Then you have the mobile radios, which are two-way radios that are used in a vehicle. Most are actually mounted on the inside of that vehicle. But remember, they have lower transmitting power than the actual base stations do. Next is the portable radios, which are the handheld two-way radios with an output of 1 to 5 watts. So this is a very important radio, or one, because it allows you to communicate with dispatchers, law enforcement, your other crew members, fire departments, such, while you are still caring for that patient or when you're outside of the ambulance. I highly recommend when you are on calls that you always have a portable radio available to you, because if you ever do get into a situation, you're not going to be able to pick up the phone and dial 911 or call the dispatch center. At least with the portable radios, there is a button on the side of it that you can push, and you can at least hold that in so the dispatcher can hear what's going on. And some departments have the emergency button, so it's just an orange button on the top or the side that you push, and then when that happens, it automatically opens up your speaker. And so every communication or everything that's going on, the dispatchers can hear, so then they can get you the right resources, law enforcement, or whatever you need, but that is only in an emergency situation. Then you have the repeaters, which are devices that are used when transmission must be carried over a long distance. So the repeaters might be in the ambulances or placed in various areas around an EMS system. So the repeater picks up signals from lower power units such as those mobile and portable radios, and then retransmits them to a higher power. So then the retransmission is done on another frequency. Then you always have the cell phones, which are, transmit through the air to a cell tower. So in many areas where the distance or expenses are too great to set up the conventional EMS radio systems, cell phones allow EMS communications, though, and through that already established commercial system. I'm pretty sure most places in Minnesota do have the radio options, but maybe way up north might not yet. And then you have telemetry, which is the process of sending and receiving data wirelessly. So in EMS, this may be on your cardiac monitor. Some monitors have it, some don't, where you can actually take their vital signs and other patient-related data, and then you can pass that on to the hospital that you're taking that patient to. So some systems do allow EMTs to acquire that and transmit it to the hospital, but others, it is just the paramedic. So you, again, have to go back to your local protocols and check that out. Then you have new technology developing almost constantly. So there's computers and tablets and these little like cell phone looking things and all sorts of stuff. You have backup radios in many systems, and then radio systems require preventative maintenance and care. So it's not just put the radio in the truck and leave it. You actually have to maintain it for it to actually continue to work. So here's an example of an EMS communication system using repeaters. All right, radio communication. It is regulated by the Federal Communications Commission, the FCC. It assigns and licenses designated radio frequencies and prevents interference with emergency radio traffic. It also prohibits profanities and offensive language. So just be very careful when you are on the radio, because anybody can hear you. I mean, right now, people could the new systems that they have out there are meant for somebody that is in Perham, or Detroit Lakes or Fergus Falls or Park Rapids or wherever, to be able to respond to an emergency in, say, Fargo-Moorhead area or St. Cloud area. And you don't have to have special radios. You already have a radio in your truck. So you can change to channels that you can talk to people in St. Cloud and Minneapolis and Rochester and such. So just be very cautious about what you're saying on the radio, and you should use the utmost professionalism when you are on the radio. All right, so here's the box 17.1 Principles of Radio Communication. So follow these principles when using the EMS radio system. 1, make sure that your radio is on and the volume is adjusted properly. You want to reduce any background noise by closing the vehicle windows when possible, and standing outside in the wind is very bad. So you want, if it's really windy out, you want to make sure that you're covering yourself or putting your radio inside your jacket so it cuts down that wind noise. You want to listen to the frequency and ensure that it is clear before beginning a transmission. You want to press the press to talk button on the radio and then wait at least 1 second before speaking. This actually prevents cutting off your first few words of transmission. Then you want to speak with your lips about 2 to 3 inches from the microphone without yelling in it. You want to use just a simple tone. When calling another unit or base station, use their unit number or name followed by yours. So dispatcher, this is ambulance 2. If the unit you are calling tells you to stand by, wait until they tell you that they are ready to take your transmission. You want to speak slowly and clearly so they can clearly understand what you're saying. Keep the transmission brief. If it takes longer than 30 seconds, you want to stop. At that point, pause for a few seconds so any other emergency traffic can use that frequency if necessary. And use very plain English and avoid any codes. Do not use phrases such as be advised. These are implied and serve absolutely no purpose. So there's no reason to put extra language in that you don't need. Courtesy is assumed, so there is no need to say please and thank you and you're welcome. Again, it's just taking up more radio time. When transmitting a number that might be unclear, 15 may sound like 16 or 50. So give the number and then repeat the individual signs or digits. So say 1515 or 1616 or 5050. Anything said over the radio can be heard by the public on a scanner. So do not use the patient's name over the radio. For the same reason, do not use profanities, statements, or anything that could tend slander to any patient. And use objective, impartial statements. If we use we instead of I as an EMT, you will rarely be acting alone. And then affirmative and negative are preferred over yes and no because the latter are difficult to hear. You want to give the assessment information about your patient, but avoid offering a field diagnosis of the patient's problem. For example, you can say the patient complains of abdominal pain rather than the patient probably has an appendicitis. And then avoid slang or abbreviations that are not authorized. And use EMS frequencies for only authorized EMS communications. Radio transmissions throughout the call. So the initial call often comes via telephone, maybe radioed from another agency. So without prompt and efficient dispatch and receipt of information, ambulances can be sent to the wrong location. Most radio communications in EMS take place between the field personnel and the dispatch. So common processes make communication more efficient. So dispatch records all of the times according to a 24-hour clock. So they go off from the original call. So when that person called 911, what time did they call? What time was the ambulance dispatched? What time was they reached the staging area or when they got to their station and en route? And then the ambulance arrived at the scene. So the dispatchers gives times after most transmissions. So if you say ambulance 5 were en route, dispatch will come back and say 10-4, 11-34, or ambulance 4 en route or on scene, ambulance 4 on scene, dispatch would come back and say 10-4, 18-25. Okay, so they're going to give you that time, and those are the times that you should be putting down on your reports, because those are the times that if for whatever reason case would go to court, those are the times that they're going to use, is what the dispatch information was. Many transmissions are between the mobile radio within the ambulance and the dispatch at the base station. In some EMS systems, simple standard communications are transmitted by pushing a button on a mobile data terminal, which is mounted in the ambulance. You want to always carry portable radios with you whenever you leave your unit, just in case you get into a situation. Make radio communications your priority, because you will hear when you start working in EMS, and maybe some of you already are part-time or whatever, doing ride-alongs. When you listen to the radio and you have, say, a fire department that is going into a house fire and they're absolutely yelling on the radio, can you hear what they're really truly saying? And the first thing that's going to happen is, if they hear yelling on the radio, the dispatchers, the law enforcement, they're all going to be like, what's going on? And then they're going to stop listening to everything else because they're focused on what is going on with this one thing. And here they may have been on, the fire department may have been on the wrong channel, and they're just trying to get the attention of somebody else on scene. But what it does to everybody else in the county, especially our county, because most counties have their own dispatchers, that's where the problem comes in, is then they stop doing what they're doing to listen to this guy yelling on the radio. So just be very careful with that. All right, radioing medical reports. So a report must be given to the destination hospital so it can prepare for the patient arrival. So reports can be given by radio, verbally, in person, or in writing, or in all three ways. So sometimes they'll actually call and give a brief report when they're in the back of the ambulance, and then they'll also give a full report when they get to the hospital. Then the radio report is specifically structured to present only the most important information. So you could say, Ambulance 2, we are en route to your facility with a 49-year-old male who is complaining of chest pain, shortness of breath, blood pressure is 180/90, pulse is 110, respirations 20, will be to your facility in 12 minutes. Do you have any questions? So that is how it should be done. Very short, simple, sweet. You've got the age of the patient, you got that he's male, which again doesn't really necessarily matter, but you've got a 49-year-old male who's got abdominal pain. You gave them their blood pressure, or you gave them their baseline vitals, and then we'll be to your facility in 12 minutes. Do you have any questions? Because then at that point they can ask you, has this patient had, whatever, how long has this been going on? Is it, whatever. But typically on the radio, they don't ask a whole heck of a lot of questions. They just say 10-4, we'll see you in 12 minutes. So that's kind of it. And then paint a picture. You're trying to paint a picture of what's going on. If the patient says they're in 10 out of 10 pain, you can throw that in your report. 49-year-old male with severe abdominal pain, complaining of 10 out of 10 pain, blood pressure 180/90, pulse 110, and respirations at 20. Will be to your facility in 12 minutes. Any questions? So it's very quick and simple. Then you have the communication from the ambulance that can be by radio or by cell phone. And typically in most situations, they would prefer that you would call on the cell phone to a facility, because then you can give them a little bit more detailed information. But if it is a trauma or something where you got a lot of stuff going on and you don't have time to pick up the cell phone, you can actually do the quick radio report just as I did in that previous slide. All right, medical radio reports. Unit identification and level of provider. Estimated ETA or time of arrival. Patient's age, sex, chief complaint, brief, pertinent history of the present illness or injury, and any major past illnesses. Okay, so that's what they want to know when you call in. They also want to know the mental status, baseline vitals, pertinent findings of the physical exam, emergency care given, response to any emergency care that you did give, and then contact medical direction if required or if you have any questions about what's going on. There also might be certain medications that as EMTs, you can give up to 2 doses, but then after that, you have to contact medical direction to give a 3rd dose. So always be sure that you know what you can and can't do. Communicating with medical direction. You want to give clear information and very accurate information. After receiving the order or denial for medication or procedure, you want to repeat back word for word of what that online medical direction said. So if the order is unclear, you want to ask the physician to repeat what they said. If the order seems inappropriate, that's when you want to question them. So if they tell you, I want you to give 50 milligrams of morphine, and you're like, whoa, that's going to knock out a horse and then some, you can say, you can repeat it back and say, you want to give morphine 50 milligrams, 50 milligrams to this patient, question mark, or not question mark, but as a question. And then if they say yes or affirmative, then you can say, if you're comfortable with what your doses are, you can say, to confirm one more time, you want morphine at 50 milligrams instead of 5 milligrams. That seems like a high dose or whatever, whatever it may be that you're comfortable or not comfortable with. But just remember, physicians are humans. They do make mistakes once in a while. So if you know that that's the wrong dose, I would be very cautious to give it, because in the end, it's going to be you that's going to be put on that court stand. In this section, we're going to talk about the verbal report. So the verbal report, it is given upon arrival at the destination. Introduce patient by their name and give complete and detailed report to the nurses or physicians or whomever is there. Elements of the verbal report include what their chief complaint is, the history that was not given previously, the assessment treatment given en route, and then any additional vital signs taken en route. In this section, we're going to talk about interpersonal communications. Team communications. This is going to be the hardest thing that you will probably ever do in this class. Okay, except for take the National Registry test, but we won't talk about that quite yet. So first thing, EMTs must communicate with other people that are involved in the patient's care. You're going to have to talk with first responders, advanced EMTs, paramedics, home health aides, family, nurses, physicians, anesthesiology, lab, so on, so on, so on. Okay? You're going to have a wide range of people you have to communicate with. Speak candidly and respectfully to gather information about the patient and complete any necessary and appropriate transfer of care. Therapeutic communication is communication techniques learned by experience. So it may be more difficult with those in crisis. So everyone can improve communication skills by learning effective communication techniques. And when they talk about therapeutic communication, if you're not a nurturing type of a person, so let me do 2 different examples. So if I walk into a home and a male is in cardiac arrest, or a female, whichever, the spouse is in cardiac arrest, and you have an extra person there that is able to go and sit and talk with the significant other. So I would come across and say, as an empathetic person, I would say, just so you're aware, I'm very sorry for what's going on, blah, blah, blah. At this time, the machines are doing all the work for your spouse. Lucas is doing the chest compressions. Your spouse does not have a pulse. The team is breathing for them, and explain to them what you're doing. Now, if you're somebody who's not very empathetic and just say, yeah, so anyways, your spouse is in cardiac arrest and we're doing whatever we can for them. So the difference between the 2 communications are going to completely change the trust level that family member or family members have with you and your team. So make sure that you're very cautious about that, because it might not even be a cardiac arrest. It might be something totally different. It might be, a kid got stung by a bee or whatever. In their mind, that is an emergency. In your mind, you can take care of it and it's probably going to be just fine. But they don't know that. So with that being said, you have to be very careful with how you communicate. If you come across cold, they're not going to trust you. So just be careful. All right, you're going to want to use eye contact. You want to show interest, attentiveness, and comfort. Be aware of a position and body language. Face the patient at eye level with arms down. Communicating with patients and the family or others who are in a crisis requires skills and tact. And some people have it and some people don't. Okay? So just be very careful and cautious of what that patient is seeing. Not what you think you're portraying, but what the patient and their family is seeing from you. Use language that the patient can actually understand. Do not use any medical terms and explain the procedures that you are doing. You also want to be honest. Dishonest ruins that confidence and the rapport with the patient. So especially with kids, if you tell them that, oh, I need to start an IV, it won't hurt. But in their mind, it is the worst thing in the world, and it probably does hurt. I mean, people don't like to get IVs all the time. So just be very cautious and be very honest with them. If they ask you, does it look like my foot is broken? You can say, it looks like it's broken. However, I don't have an x-ray machine, so we can't tell for sure. It could just be a sprain. The other thing is using the patient's proper name. It is a sign of respect, especially with those older patients. Plus, it gives them the trust that you actually remembered what they said their name was. So listen, it's important to establish that trust. You want to position yourself at or below the patient's eye level to be less intimidating and to aid in the communication. Some special considerations are always to be compassionate and respectful, even if the patient has a mental disability, has visual or hearing impairments, or has any language barriers. So you always want to be compassionate and respectful, no matter who the patient is. With the pediatric patients, you want to come down to their level and again, be truthful. You can assume that a kid is going to try to hide from you because you are a stranger to them. So if they're hiding behind mom's back or under her arms or whatever else, you have to be prepared for that. If you have a kid who is laying in mom's arms and doesn't care what you're doing, you can probably bet that that kid's pretty sick. And again, staying at the child's eye level or lower, it just helps them feel a little bit more comfortable and that you're not overpowering them. In this section, we're going to talk about the pre-hospital care report. So a pre-hospital care report is written documentation of what happened during the call. So there's several forms out there that can be used. It can be a handwritten, it can be a laptop, a tablet, might be pen-based computers, and so forth. Those are dropped off or transfer the report to the facility. Functions of the pre-hospital care report include the document findings and the treatment. It conveys a picture of what the scene was, and it's entered into the patient's permanent medical records. So everything that you put on that report has to be the truth. It cannot be your opinion. It cannot be anything that you think it might have been or what that you think they may have wanted to say. It has to be truthful into what the patient said. It is also a legal document, so it can be subpoenaed and used as evidence. It may also help the patient win a case. So it also, hopefully not, but it could also be used against you in a case of negligence. So if you are not one to like to transport patients to the hospital when they call 911, you better know how to write a really good report, because a report on a transported patient should be way less than a transport for a non-transported patient. So if you leave the patient, if they call 911 and you leave them at home, Your documentation better clearly and very evidence-based tell you why, or tell the, writing it should say why you did not take them to the hospital. Because if they end up being found deceased in an hour from when you left the scene of their home, the question is going to be, why didn't you take them to the hospital? They called 911 and you didn't take them. Why not? So that better be clearly defined in your report. If you tried to talk them into going to the hospital and they absolutely refused, and there's family members there or law enforcement or other people besides your team, have them give you their name so you can use them as a witness that this patient said no. It also has administrative data, including the insurance information and billing address. It has education and research, so it has clinical research, statistics, continuing education, and then tracking the EMT's personal experience. You also have what's called quality improvement, which is a routine call review. So some departments do it after every single call. Others do it for all trauma patients for 1 month. And the next month they might do it for every cardiac patient. Or they might do it for every time you administer oxygen. So it just depends. So it ensures compliance to the standards of what you should be doing. It can reveal providers deserving special recognition, but it can also reveal opportunities for improvement on that patient or on that crew member as well. So elements of the pre-hospital care report. So data elements are developed by the National Highway Traffic Safety Administration, also known as NHTSA. More than 400 elements are involved, and minimum data set available is nationwide. So when you run data, you get the agency's name, date, times, call number, unit personnel, and levels of their certification, and any other basic information that's mandated by your service or potentially even your state. So use official times given by the dispatch so all times are in the report actually match. So patient information is name, address, and phone number, sex, age, and date of birth, their weight, their race or ethnicity, and then billing and insurance information. So you'll have also information gathered during the call. So your general impression of the patient, narrative summary of the call, the patient's prior aid, any past medical history, physical exam results, vital signs, ECG results, procedures and treatments, medications administered, and other information as required by your service. And then, of course, transport information. Next, you have narrative sections, which is an objective information. It's observable, measurable, and verifiable. And then subjective information is subject to your interpretation or your opinion. It's often reported typically by the patient. Then you got your narrative section, which includes the chief complaint. The primary complaint is actually what is stated by the patient and is best directed as a quote. And then it has your pertinent negatives, which is important negative findings of that patient. So narrative sections also include avoid radio codes and non-standard abbreviations. Write legibly and use the correct spelling. Information must be read easily and accurately. And the PCR is a reflection of your care. So you want to use appropriate medical terminology, and if it is not written down on your report, just remember you didn't do it. Even though you can say, I gave that patient that had an O2 stats of 85, I did give them oxygen. I know I gave them oxygen. Well, guess what? When you're in court 3 years after the call and it's not in your report and their O2 stats were at 85%, you're probably going to go down for negligence because you failed to give them oxygen, even though in the back of your mind, you know that you gave them oxygen. If it's not in the report, you didn't do it. In this section, we're going to talk about special documentation issues. Okay, first we're going to talk about legal issues. And what the biggest legal issues is confidentiality. So you cannot talk to anybody and tell them anything that you've seen with the patient or did with the patient, or that you even essentially went to their house. So confidentiality is very, very important. So covered by the Health Insurance Portability and Accountability Act, so HIPAA, and accountability and security. So with patient refusals, there's high liability with that. You have to document all details in a refusal of care form. It's extremely important that if a patient refuses, they are given fully 110% information about what could potentially go wrong and so forth. If you ever have another family member, law enforcement, another agency, personnel, whatever there, to be able to sign the form stating that they witnessed that you gave them the conditions of refusing and that they could potentially die and so on, so on, so on. It's very, very important. All right, next we're going to talk about falsification. So covering up errors and recording something that you forgot to do is falsification if you change it. So pre-hospital care reports document the information obtained and the care rendered during that call. So false entries or misrepresentation on a report are usually intended to cover up serious flaws in the assessment or in the care. So falsification may actually make the problem look worse than what it is uncovered. So there's two types of errors. One is the omission and the other one is the commission. So the errors of omission are those in which an important part of the assessment or care was left out. Like an example is oxygen. So if the patient is experiencing shortness of breath, oxygen is an appropriate treatment. If it is overlooked for any reason, then never write that oxygen was administered when it wasn't, because the patient, their family, and so forth are going to remember that you didn't put oxygen on them. So just be very careful with that. And then when you document situations surrounding any errors of omission or commission and explain exactly what happened, document what was done to correct the situation, including advising medical direction and verbally notifying the hospital personnel. So when you do have a falsification or misrepresentation on a hospital care report, that leads to poor patient care because the facts were not documented. And then hospital personnel might be misled about the patient's condition and the care that they received. Furthermore, they're not going to trust you as a provider. So it also may lead to your supervisor suspending you or revoking of your certification of your license as an EMT. So there's a lot more steps to it, and your medical director can make that decision to not allow you to work under his or her medical direction. So you will avoid falsifications if you just follow this simple principle. Writing everything is very important that did happen and nothing that didn't. So if it happened, write it down. If it didn't happen, don't write it down. Your opinion doesn't mean nothing when it comes to a patient care report. It is factual information. Next, we're going to talk about correcting errors and mistakes in documentation or adding. So the pre-hospital care reports are not always written in ideal circumstances. You may even find yourself being dispatched to another call before you finish writing your last call. So in situations like this, you may inadvertently write incorrect information on the report. Anytime there is incorrect information on the report, it must be corrected. So if your system uses an electronic PCR, without paper copies, you can log in and get access to that PCR. But you may need an administrator at your service to unlock it for you and then correct the data and add an addendum that explains the change and why you made it. They don't want you to just go in there and change it after you realize that, oh, hey, I forgot to give oxygen and I should have done that because that oxygen was at 85%. They don't want you to do that. The other side of it is if your system or if your service still uses paper reports and the form is still intact and all copies are attached and not yet distributed to the hospital and so forth, or if you are correcting the paper copy of computer generated form, you want to just draw a single horizontal line through that arrow. You want to initial it and then correct the information beside it. Do not completely cross out the error or erase it or get rid of it. I mean, you just don't want to do that. That may appear that you are attempting to cover up a mistake in patient care. So again, following your agency's guidelines for changing information in a computerized REM report or a paper report or whatever is very important. So changes are usually logged on a computer system. Changes are usually logged with the date and time that the change and the name of the EMT who made that change. So it is important that changes are identified and the report is marked as amended. So you may need to send copies of the amended report to those who received it previously. So if there is an error though that is discovered at a later date and after the report has been submitted, again drawing a single line through that error and mark the area with your initials and the date and then add that correct information. Or you can even put it in a separate note. So this should be done, ideally it should be done in a different colored ink when possible so that the change would be obvious. All right, here is our think about it. You respond to a call for an unconscious male. Upon arrival, the patient is awake, alert, and walking away. He states that he was just sleeping and does not need or want treatment to transport. What are you going to do? All right, another think about it. Is this a patient? Is a complete assessment and physical exam needed? How will you document this call? And should you obtain a formal patient refusal? So first and foremost, a complete assessment and head-to-toe physical exam is probably not needed at this point. The patient did not call EMS and appears to not need it. Your limited interaction can give much information for documentation. So the patient is awake and alert and there's no obvious distress. He has no complaints of pain, illness, or injury, and there's no obvious trauma, and the patient moves all extremities and ambulance without any assistance. Your chart should at least include the brief assessment that you did along with other details of the event. So again, local policy may require a refusal. So if so, do not forget a witness and a patient signature. I mean, it's always good to have a witness signature just in case. All right, multiple casualty incidents, a logistical problem for EMS. Why is that? Well, there are many patients or injuries. There could be multiple vehicle collisions, a major fire, a plane crash, causes many logistical problems for the EMS system. So documentation of information for individual patients may be very difficult. Patients in a multiple casualty incident or an MCI will probably be moved from one treatment area to another at the scene and then receive the transport to the hospital. So the patient may be transported to several different hospitals because of the mass casualty incident. So it's important to keep information with the patients from an MCI scene as they move throughout the system. This is often done throughout using a triage tag, which we will go over in class. And this tag is affixed to the patient and used to record the patient's chief complaint and injuries, their vital signs, their treatment given, and then later in the emergency, the tag will then be used to complete a traditional pre-hospital report. So when completing that pre-hospital care report for that patient involved in an MCI, it will not be possible to provide the details that you would normally provide for a single patient call because you may not be around them for very long or from start to finish. So this is obviously an understandable consequence of the EMS or of the MCI. So take that into consideration, but your region or agency may have requirements for what information must be completed on your report during an MCI. And again, going back to your local protocols to make sure that you know what that all is. All right, special situation report. So your activities as an EMT may also take you into some unusual situations that may require documentation on a form other than a pre-hospital care report. Such forms are usually specific to your local agencies rather than mandated statewide. So some examples of situations that might require this kind of special report include an exposure to an infectious disease, an injury to yourself or another EMT, hazardous or unsafe scenes, referrals to social service agencies, and mandatory reports of child or elderly abuse. All right, let's do a quick chapter review. When calling in patient information, you want to be sure to include these elements. the unit identification and the level of the provider, estimated time of arrival, patient's age and sex, chief complaint, and brief pertinent history of the present illness. Any major past illnesses, mental status, baseline vitals, pertinent findings of the physical exam, emergency medical care given, and response to the emergency medical care. So when calling in patient information, you want to include these elements. Contact made with medical direction if required, or if you have any questions. And then when completing the pre-hospital care report or PCR, you want to include the patient's name, the address, the date of birth, age, and sex. You want to also include the billing and insurance information, the nature of the call, mechanism of injury, and location where the patient was found. You want to include the treatment administered before arrival of the EMT by bystanders, emergency medical responders, or others. You also want to include their signs and symptoms and baseline and subsequent vital signs. You want to include the secondary assessment, care administered, and the effect that the care had on the patient, improved or if there was no change, and then changes in the condition throughout the call. A PCR may be a legal document in a court proceeding. The PCR should be completed as soon as possible after the completion of the call. Data from the PCR may be helpful determining future treatments, trends, research, and quality improvement. Your report should paint a picture of your patient and their condition. You want to accurately describe your contact with the patient throughout the call. Remember, medical communication comes in many forms and is essential to team-based patient care. The medical radio report is structured to present pertinent facts about the patient without providing more detail than necessary. Remember, a proper verbal report will include the chief complaint, any history that was not given previously, additional treatment given, and additional vital signs taken en route. Remember, interpersonal communication is often challenging in EMS. Adopting best practices can improve communication capabilities significantly. Confidentiality, patient refusals, and falsifications of records are all important legal concepts that the EMT must consider when documenting a call. Questions to consider. How can you improve your interpersonal communication with patients and team members? And what is the objective and subjective information in the narrative portion of the PCR? Critical thinking. You want to organize this random information and present a radio report to the hospital. So the patient has chest pain radiating to the shoulder, 56 years old. Oxygen is applied at 15 liters per minute via non-rebreather. They're alert and oriented, and it is a female. How would you put together a radio report with this specific information? I would say you have a 56-year-old female who is alert and oriented with chest pain radiating to her shoulders. There was oxygen applied at 15 liters per minute via non-rebreather. So it came on 20 minutes ago while mowing the lawn. History of high blood pressure and diabetes. Pulse is 86, respiration's 22. Skin is cool and moist, and blood pressure is 110/66 with an SpO2 of 96%. So with this being on two separate slides, how are you going to do a good report if you don't have all the information in one location? So this is also another good little concept here in critical thinking side of things, that if your partner has some information and the rescue squad has some information and you have information, you're going to probably forget something that's pretty important. So that's how I would work that. As you bring on more information, you know that the oxygen relieved the pain slightly. She denies any difficulty breathing and requesting orders for medical direction. You are on a community BLS ambulance 4. So now they want you to organize this random information and present a radio report to the hospital. So the lung sounds are equal on both sides, placed in a position of comfort, and ETA is 20 minutes away. So with the stuff that you would remember, so how would you write a report from the same call? So will you use any different information? As far as I'm concerned, I would use every bit of the information that you received, but you're going to have it all in one area to be able to give a good, accurate report.